So if you look back 10, 20 years, we've really had an evolution in our ability to classify breast cancer. So we used to just look at a histopathological diagnosis. Is it a ductal? Is it a lobular? What is the proliferation? What's the grade? And so from there, we've gone to a classification looking at immunohistochemistry, so looking at the estrogen receptor, progesterone receptor, and looking at ERBB2 or HER2. And that has led to some targeted therapies that helped really improve the number and efficacy of therapies that we can have for different subtypes of breast cancer. And more recently, though, we've looked at what we call the molecular classification. So looking at some of the earlier first generation sequencing, and now we're looking at next generation sequencing. But what's really most interesting is the fact that we used to need large amounts of tissue for analysis. Now we're actually using less and less, fewer amounts of tissue, even looking at single cell analysis, and the number of technologies we're now looking at whole exome sequencing, so our ability to understand the tumor has improved significantly. We're also doing, as you know, liquid biopsies and looking at changes over time. Now, in that context, though, we also have to understand some sort of key themes. So the first thing is looking at what we call a multi-level omic approach, and integrating all that. So not just looking at genomics, but looking at proteomics, metabolomics, bringing it all together, looking at the microenvironment, understanding the interplay between all of these things, and then using our colleagues in bioinformatics to bring it all together to help us help patients. So let's start maybe with just understanding the concept of heterogeneity. So we used to formally think about it as, okay, your cancer is different from your cancer. But now we actually realize even within a given patient, what might be growing in the breast. So in the breast tumor, in the breast, there might be certain areas that are hormone sensitive and certain other areas that are HER2 positive. We may compare the breast to what's growing in the liver or the lung, and it actually may be different. So it's intra-patient and inter-patient variability. And so selective clones may have the propensity to grow in the lung and brain, whereas others don't. And that makes our job quite complex. So I may have a patient on treatment where whatever I'm giving them is responding nicely in the lung, but the liver disease is growing. And a lot of the future is helping us understand why is that so. So some of the other things that we're looking at in terms of classifying breast cancer also is looking at the concept of tumor evolution. So this idea, Lucy Yates and colleagues from the UK have really helped us understand these branches and understanding what happens to a cancer over its lifetime. So what we call this selective pressure. So when you treat with a particular anti-cancer agent, what happens is you get feedback mechanisms and you allow certain clones to grow. So you give one tumor, that one responds, but maybe under selective pressure, different clones grow and become resistant to the therapy we started with. So a perfect example is from data from Urich and colleagues from Boston, where you treat with an alpha-specific PI3 kinase inhibitor, and where initially you had a wild-type PTEN, you had then exhibit a new lung metastases with PTEN loss. So it's understanding this change over time, change within the patient's own tumor, and how the therapies we give actually impact that. So I think that first little preamble is to help us realize that it's actually not so simple as just a pure, what is the classification going to be? Why does it matter, though? It matters because in breast cancer, we don't have as many as what we call driver mutations. So in lung cancer, in melanoma, we have what's called driver mutations that are strong mutations. By targeting that particular mutation, you have an amazing response with very few toxicities. In breast cancer, it's much more complex. We think there are probably much fewer driver mutations. One of the biggest success stories so far has actually been looking at germline Braca mutation status. So we know that a small subset of patients have what we call germline BRCA1 and 2 mutations. And in those particular patients, recent data from the Olympiad study looked at a drug called a PARP inhibitor. And it looks like a PARP inhibitor as a single agent targeted therapy is efficacious as compared to just standard chemotherapy. Now, the most important question is, how can we exploit that? We call that term synthetic lethality, and it may be that combinations of therapies with PARP inhibition and chemotherapy might be optimal to PARP inhibition alone, or maybe it's just maintenance therapy. But germline BRCA mutation status, that study with the Olympiad is one of the first proof of concept showing us one mutation potentially predicting benefit to therapy. Now, the future really is this concept that everybody likes to talk about, whether it's personalized medicine, precision medicine. So identifying, biopsying a breast cancer tumor at that given time, looking at it, finding out what its vulnerabilities are, and what the best one treatment is, or potentially multiple treatments. So take, for example, immunotherapy. So immunotherapy in melanoma, in lung, these are established therapies. In breast cancer, we know that a small subset of patients have a really impressive response, a durable response to single agent immune checkpoint inhibition. But there's a fairly large group of patients that don't have what we call an inflamed tumor that benefit from just single agent immunotherapy. They may need combinations, so combinations of activating the immune system and then blocking it, or they may need a combination of chemotherapy and immunotherapy, or maybe even radiation and immunotherapy. So the future is really figuring out at an individual level for breast cancer patients who needs single agent, who needs double. So this idea of, again, personalized therapy to give the best therapy possible with the least amount of side effects, and we call that the therapeutic ratio. Now, the truth of the matter is right now, how we identify treatment for patients is most of the time using immunohistochemistry, so looking at ER, PR, HER2. Right now, we also are looking at germline Braca mutation status, but I think in terms of individual genes and pathways and signatures, our hope is that's what's the future, is looking at not just one gene, but likely a complex signature of genes that helps identify the best treatment for a patient.